Okay, welcome back. Good afternoon, everyone. Hope you had a nice lunch break. There's a lot of interaction going on, and I'm glad the weather was nice enough that many of you were able to get some fresh air and sit outside for a while. And hopefully, really enjoyed the poster sessions. We'll be having another series of posters tomorrow with another group of scientists who have been selected to present. So thank you. Mr. Botticelli is just arriving, but just to give him a few minutes to get into the building, we decided to move forward and have Dr. Peggy Murray speak, who'll be speaking on behalf of one of our number of NIH sponsors of the conference from NIAAA, Alcohol Abuse and Alcoholism Institute. So with that, let me introduce Dr. Peggy Murray. Peggy.
Hi, thanks, Jack. We were really excited to hear that NIDA was doing this meeting, and we signed on right away. I, first of all, want to bring greetings from Dr. George Koob, our director, who couldn't be here this morning and asked me to fill in for him. As you might expect, there are a number of places where the marijuana research agenda would intersect with the research agenda of NIAAA. And I just chose 5 to talk about this morning because I only have a few minutes. And I hope that we'll get at some of the things that we still need to know and how we're developing our research agenda at NIAAA. The first one, consequences of prenatal exposure. We've already heard some questions about that from the audience, and I'll just say a few words about that. Number 2, the effects of alcohol and marijuana use on adolescent development. You've heard a great deal about that from Dr. Susan Tapert. But I'm going to say a little more about what areas of research we're interested in. Alcohol and driving has been a big research area for NIAAA, and now we're very interested in the combination of alcohol and marijuana and driving. Our very large National Epidemiologic Survey on Alcohol and Related Conditions, known as NISARC, is showing some really interesting and important new data on marijuana use and the prevalence of marijuana use disorders. And then our understanding of addiction and marijuana actually helps increase the understanding of addictive disorders all around. Okay. All right. This work comes out of the lab and the group of Dr. Kathy Sulik, who was actually responsible for some of the important seminal work on proving that alcohol was a teratogen. And her animal or mouse model of fetal alcohol syndrome has been, really important as we've worked over the past 30 to 40 years to show that alcohol does have important negative effects on the developing fetus. Her group has also started to show the dose-dependent teratogenicity of the synthetic cannabinoid in mice. And Scott Parnell, who's here and has a poster that I'll put in a plug for, actually is also starting to show some deleterious effects on the developing fetus of alcohol and marijuana use together, or alcohol and synthetic cannabinoid use together. So I think it's important to pay attention to the work of this group and also to expand it. As I said at NIAAA, we're very interested in that. Now, alcohol and adolescent development. You know that both NIDA and NIAAA are interested in alcohol as well as marijuana and its effect on the developing brain, adolescent brain. This slide is a study from 2011, and I put it up here because we started to see that drinks per day seem to have an effect on attention as well as executive function, and marijuana use showed an effect on memory. However, I also think this shows a lot about what we still need to know. We need to know such things as what comes first. Is it the drug, or is it the exposure to the drug, or is it deficits that were already there in the first place? And, as we've gone along, we've increased our sophistication and tried to do things to answer that question. What they did in this study was they looked at one group that had substance use disorder, and they compared it with another group of adolescents who were family history positive for substance use disorder but were not using themselves. I don't know that that really answered the question, but it shows some of the problems or the issues that we're trying to deal with. It also, we have to find out if effects are chronic, Are they acute? Or are they both? And so as we funded more studies, we've looked for those things that will elucidate that. Now, these are two articles that come out of the University of California, San Diego, and the groups there who will be involved in the ABCD study, they're also currently involved in Canada. They found some really important, as you saw from Susan Tapert today, some really important deficits in young adults or teenagers, I guess it's both, it's age 16 to 19, who use marijuana and alcohol at the same time. And you saw her explanation of how there are deficits in complex attention, memory, processing speed, and visual function. But what these two papers were showing also is important, and that was that the early onset of marijuana meant greater deficits, but also the kids in the study who were suffering alcohol withdrawal symptoms in the abstinent phase also had poorer outcomes. So while the different substances have different effects separately, the combination of the two substances also had unique effects. And it's important for us, I think, to tease those out, especially in adolescents, as we saw from the previous session. Now, the presence of marijuana in fatally injured drivers, if you see that very top line, that's drivers who are between the ages of 18 and 20. And you see that it's increased from 2005 to 2013. But what's, I think, really important about this slide is that only 9 states test for the presence of marijuana in drivers and fatal crashes. 9 states that test more than 70% of fatally injured drivers. And in alcohol, every single state tests for alcohol. Dr. Ralph Hinkson, who is the one who filled me in mostly on this, was saying that back in the 70s, when only 17 states reported alcohol, we were at a loss. So the fact that only 9 tests for marijuana is important to note, and in order to develop evidence-based prevention policies and policies around what would be a legal marijuana limit, we have to know more about what drivers who are involved in crashes are doing. Now, we don't have a lot of studies that show that marijuana is increasing traffic crash risk, but this study showed that cannabis in 23 out of 36 studies was responsible for an increased risk in traffic crash. Most of the studies in this particular review were done outside the United States where cannabis was concerned. But I think the important conclusion was that the combined use of alcohol and any psychoactive drug is associated with the highest traffic safety risk. The National Epidemiologic Survey on Alcohol and Related Conditions is an important study that's been funded by NIAAA for many years. We're just completed Wave 3. This table shows the difference between Phase 1, which was data collected in 2001 and 2002, on the prevalence of marijuana use disorders. It's not surprising because this study also showed that the use of marijuana itself more than doubled in this time period, from 4.1% in 2002 to 9.5% in 2013. You can see that in every category of sociodemographic characteristic, there is almost in every single one, there's a statistically significant increase in the marijuana abuse or dependence. So this study, which is repeated every 5 years, will actually be a very good indicator of where we need to focus our attention. And finally, I'm just going to say that the understanding of the commonalities and synergies of alcohol and marijuana disorders can improve the treatment for both. This wonderful diagram that we can thank Eric Nestler for kind of shows the complex relationship of all the drugs of abuse and how they work. And it's in understanding where they're similar and where they're different that we can start to develop treatments that can be effective. you know, it was realizations like this that has led to the development of the collaborative research on addictions at the National Institutes of Health, otherwise known as CRAN. And it's a joint workforce effort by the National Institute on Drug Abuse, NIAAA, and the National Cancer Institute's Division of Cancer Control to work together to look at prevention, treatment, and what we can do to advance our understanding of addiction and how to combat it by working together. So while we used to study substances rather separately, now the three institutes are working together in a major way to focus on all substances. The ABCD study, which you heard about from Dr. Tapert, was actually, actually comes out of this CRAN initiative and the three institutes working together. So with that, I'd like to thank you.
Thank you very much, Peggy. With that, I'd like to bring back to the podium our director, Dr. Nora Volkov, to give some introductory remarks for our next very special guest speaker. Dr. Volkov.
Thanks. It's a pleasure for me to be able to introduce Mr. Michael Botticelli. He's the director of the Office of the National Drug Control Policy. He was unanimously approved into that position in February of last year, even though he came to ONDCP for the first time in November 2012 to be the acting deputy director. And since then, he has exerted an extraordinary leadership. As the director of this office, he's in charge of drug policy efforts in the United States and has followed a very balanced public health and public safety approach. As I think of Michael Botticelli, I cannot think of a better leader as it takes in terms of pushing the value of science as a tool in order to be able to inform policy measures. So in the whole area of drug abuse field, this has permeated very much the actions of his office on the one hand. The other area where he has exerted an extraordinary leadership is in the notion of substance use disorders as medical diseases and in the importance of communicating this to the public and to the public health care systems in order to change them, and on the one hand to decrease the stigma associated with substance use disorders, but on the other one to create an infrastructure that is needed in order to treat them. And I cannot think of a better advocate to do that than him. So it has been a pleasure to work with him throughout all of these years. Before coming to ONDCP, he was the director of the Bureau of Substance Abuse Services at the Massachusetts Department of Public Health, where, again, he did an extraordinary job in implementing prevention and treatment measures that have been one of the most innovative in the United States. So he has played an extremely important role in terms of advocating for science in policy making, in advocating of the consideration of substance use as medical illnesses, and incredible advocacy to destroying the stigma associated with substance use disorders. It's a pleasure to have him here, and I'm very happy that you all can get to know him, those that you don't. Michael? Is behind
this
you.
way.
Yes.
Thank you. Thank you, Nora, for that introduction and for your partnership. You know, I just have to say I just got back from Vienna, which is where the United Nations hosts all the countries in the world talking about global drug policy. And Nora's been to this meeting a number of times to help kind of guide the science of drug policy in the United States. And, you know, each time I come back, and I know we have extraordinary challenges here in the United States, but each time I go there, I come back with a renewed perspective and a renewed gratitude, not only for the work that we do in the United States, but particularly for NIDA and Dr. Nora Volkov and her staff and the work that we do here. You know, needless to say, the research that comes out of NIH and NIDA really leads the world in terms of our ability to make good, informed decisions. So I really want to thank her and her staff for all of the work that they do and the collaboration around how we continue to focus drug policy based on science. And I also want to thank them for putting on this conference today. I think this is an incredibly important opportunity to really think about what we know about marijuana and what we don't know and what we need to do next. So I'm really pleased by being here today. So, in the timeline of marijuana research, this conference, I think, is really a marker of the progress the scientific community is making in these issues. And, throughout our history, the United States has approached medical research as a quest. Nora often talks about having a curious mind and having to constantly ask questions and seek the answers to those questions. Well, the quest to learn more about the human body and disease, that's really about how we improve people's lives. In fact, right here on NIH's campus on July 22nd, 1951, President Harry Truman spoke at the groundbreaking ceremony for the world-class clinical center. And he said something that day I think that really illustrates the point. And he said, "As we lay the cornerstone of this clinical center, I see in this structure a symbol for what is finest in our way of life. The work that is being done here in Bethesda will bring life and health to all mankind. It will save the lives and alleviate the suffering of our own children and grandchildren. But more than that, it will serve people of all religions, all races, all nations, everywhere in the world." I'm pretty sure President Truman was not thinking about marijuana when he said this, but his words, I think, can really be true as we approach conducting research on it. As all of you know, with states across the country changing their laws as they relate to marijuana and increasing access, we need to fully understand the effects of the drug in all its forms that it has on populations of every age and what potential therapeutic benefits it has for a host of medical conditions. In short, drug policy needs to be dictated by science. Imagine that. That's the cornerstone of our approach. And while we clearly know some things about marijuana, there's a lot we don't know. And we're very interested in this research because it will help answer a lot of our pressing policy questions that we have. Clearly, we need to know more about the negative effects of marijuana and its use on prenatal exposure, on brain development, and its relationship to school achievement, the risks of mental illness, lung cancer, testicular cancer, and we need to know whether marijuana and its components can be used to help manage pain, control seizures, or address other conditions. A report on non-medical use of cannabis commissioned by the World Health Organization and released last month highlighted additional questions that we need answers to, including how we can effectively scale up prevention strategies that are working, and how do we better treat people with cannabis use disorder, either from the use of marijuana or its derivatives. So there are clearly gaps in our knowledge, and the bottom line is that we need to learn more, and that's where you come in. We need your help to better understand marijuana and its effects so that we can make informed policy recommendations about where to put resources to help those impacted by marijuana use. Your efforts could result in promising medications to help alleviate the suffering President Truman spoke about 65 years ago right here on the NIH campus. We recognize that the current process for initiating research on a Schedule I drug like marijuana has been the subject of criticism, some of it even fair. For this reason, federal agencies have been working to streamline the process of conducting marijuana-related research while also meeting our obligations under the Controlled Substances Act and international drug conventions and trying to prevent youth use of marijuana. The DEA has increased the production quota for marijuana for research purposes 2 years in a row, and there are currently 330 researchers registered to conduct research on marijuana and its extracts. We have also eliminated the Public Health Service Committee review for non-federally funded marijuana research, and the DEA recently streamlined the administrative process for CBD research. Steps like these represent our commitment to streamlining research on marijuana and its constituents. In matters of life and death and of disease, treatment, and pain management, our decisions have to be guided by evidence. The more research we have, the better our decisions will be for policy, funding, resources, and targeted treatment. That's the guiding principle of the Obama administration and our national drug control strategy. As I said, this conference is a marker of progress in understanding marijuana's effects, both harmful and helpful, and our commitment to continuing research, particularly on promising components like cannabidiol. So I really want to thank the NIH, Dr. Collins, Dr. Volkov, and her staff for being here today, and thanks to all of you for being here today and finding ways to advance our scientific understanding to ultimately improve people's lives. Thank you very much.